trauma-informed care in the primary care setting to discuss tools and skills to improve patient care. Primary care clinicians see all different types of patients, children, women, young adults. It gives you the opportunity to provide so many different types of specialized care, including pediatric care, women's health, and mental health services. It makes primary care a catch-all of sorts, a specialty where trauma-informed care is even more important because of this. We've discussed the adverse impact of trauma on health, so now let's talk about ways primary care providers can implement TIC and the benefits it can.
This idea that trauma-informed care and becoming trauma-informed is this huge, heavy lift. In truth, if we don't provide services in a trauma-informed way, what is the heavy lift is services that are not effective. And so what trauma-informed care means does not have to be the most elaborate, detailed, research-heavy, protocol, assessment-based approach. It can start with education and then kind of move forward.
The training piece is really key, and it doesn't need to be expensive or too time consuming. We have 3 core trainings that we have everyone go through when they start working here, and the modules can be done in 2 hours or less.
This change process is incremental, and you can begin this as an individual person in your clinic and make a meaningful difference, not only to your patients, but to you as a practitioner. It's not radical to think that our job as primary care providers and why we went into primary care in all of our different disciplines is to actually help patients heal. I mean, that's not radical at all. It's self-evident, but it's like taught out of us. And what we're doing now in this movement towards trauma-informed primary care is to teach that back in, is to help people realize that their vision for why they went into this to begin with is to help people heal and to connect with them in that process, and to heal themselves in that process, and to have joy in that process.
We've discussed the adverse impact of trauma on health, so now let's talk about ways primary care providers can implement TIC and the benefits it can have for your patient population. The providers featured in these videos are participants in Advancing Trauma-Informed Care, a national initiative supported by the Robert Wood Johnson Foundation, aimed at understanding how trauma-informed approaches can be practically implemented across the healthcare sector. For a brief overview or more in-depth information, please see our behavioral health module. Many people who have mental disorders or substance use have experienced trauma as children or adults, and the rates of which adults experience it is staggering, at a rate of 1 in 5 each year, and it's often linked to suicide, which is the second leading cause of death among people aged 10 to 34. Using a trauma-informed care promotes a culture of safety and healing, and this can be shown with nonverbal cues like active listening to foster effective communication. This step is psychologically charged, and it is the groundwork for the successful outcome. This means letting the patient speak, engage with eye contact, and allow time for silence. Sometimes that time to sit on a thought or gain the courage to say something may take time. To show you are paying attention and ensure their point is being understood, rephrasing the situation or feelings to the patient shows that you're hearing. Empathy and rapport are key in bridging that distance between patient and provider, and is an important professional skill. Although one cannot fully experience the suffering of every patient and are not expected to experience their patient's emotions vicariously, but instead to focus on the attention of the patient and their shifts in emotional cues without detachment. This can even be applied to non-traumatic scenarios, as in a simple follow-up, then realizing a patient has stopped taking their prescribed medications. Empathy involves listening to the tone to inform your cues, and rapport is communicating based on that. Are they angry? Possibly they're having adverse reactions. Are they upbeat? Maybe they're feeling better. Flat affect? They may be feeling hopeless of ever getting well. This approach could be gleaned from a rapid-fire checklist of reasons, but it may be as efficient while engaging a patient directly to enhance their medical care. When it comes time to address behavioral change, patient autonomy is important for a sense of empowerment and may be helpful to understand how they may have approached similar situations in the past that can inform coping skills. but all decision-making processes must take into consideration cultural sensitivities. Using language of identity and conveying confidence through the interview process is the verbal techniques to connect with your patient. This includes changing can'ts to don'ts, to increase feeling of empowerment, turn shoulds to coulds, encourages divergent thinking, and think carefully when you use I and you. Although it draws attention to a point, it also suggests responsibility and blame. In general, try to improve your speech to cut out filler words like ums or uhs, and be sure to turn past to presence. It increases persuasion. Additional verbal techniques include asking the right questions without presuming the absence of an issue. Don't start too small or too big to encourage self-disclosure and revelation, and pull that out from them through follow-up questions. The starting safe is a way to build social connection before diving into emotionally charged topics. With that, it's important to realize that every conversation does not need to be solution-oriented, but sometimes someone needs to share their lived experience to feel and understand it before moving on. Through all of this, be concrete in your language to show you're clear in your understanding and show them you're listening. There may also be cases where the patient is angry or threatening, in which situation requires de-escalation. Having this training or these ideas in your back pocket can always be helpful. Maintaining safety at all times is the first step. After that, nonverbal cues, things like remaining as calm and confident in yourself as possible, is a projection of the space of neutrality patients need in that moment. Other things like staying at the same eye level, avoiding physical touch, and segregating them to a quiet, dark area to reduce stimulation and other distractions is helpful, so you can then begin to listen to the patient. Allow them to speak while actively listening before restating to show you understand. These de-escalation techniques avoid unnecessary chemical and physical restraints that assault the patient's autonomy. De-escalation techniques don't just happen in the acute setting like an emergency department, but also in the office. And it's important to begin with neutral questions that are non-accusatory. Often they're unrelated to the presenting complaint and include just basic information about them and their medical history to begin to start to build that rapport. Be sure not to use reflex phrases like, I understand, because you probably don't. Instead, reflect and restate the objective situation, like showing understanding of their anger or frustration, or the situation that was the impetus to why they're upset. While you're highlighting your support and their resilience, be honest in the level of support you can provide them. Importantly, asking directly in a patient indicated to be suicidal in what ways they have thought about hurting themselves is challenging, but it's a necessary question to address, usually after rapport has been established. Additionally, keep an eye out for the imminent warning signs revolving around firearms, other weapons, and medications that could lead to overdose. These are just a few of the screening tools for depression, anxiety, suicide, and substance abuse. Hopefully, some of them look familiar from your didactic year. If you're interested to learn a little bit more, please see our behavioral health module for a more in-depth look. As important as care is inside of the hospital or office is the steps we take to ensure safety outside the office. That decision to get treatment that may be more intensive is often contingent on how providers speak of it. Normalizing their experience and focusing on a specific issue and how that relates to their overall health is important to address that their future care is a multidisciplinary approach. Phrases like, I've observed that others, XYZ, instills the necessary hope the patient may need in that moment. Again, a common theme in this module is the discussion of the importance of the provider's onus in knowing the resources and tools available to them and their patients to serve them better. Here are some listed to get you started. And remember the discussion of the importance of the provider's onus in knowing the resources and tools available to them and their patients to serve them better. Here are some listed to get you started. And remember the National Suicide Prevention Lifeline changed in 2022 to 988. It's easier to remember, but not everyone may know that changed. Things like women can engage in behaviors that encourage their assailants, or in particular asking a patient what they were wearing when the assault occurred, if they had been drinking, or had previously consented to sex, can reveal an underlying bias in the questioner and encourage the patient to believe they contributed to their own victimization. Confronting and responding to this implicit bias can help avoid re-traumatization. The rates of sexual violence are staggering and is a keystone in medical practice because the events span all ranges that a family medicine provider may work with. The odds, sadly, are that most of your patients have experienced some form of it. We've also included intimate partner violence, as it's important to remember the haunting fact that homicide is a leading cause of death in pregnant women, and that necessity to screen for IPV. Intimate partner violence is described as the deliberate and purposeful pattern of coercive control perpetrated by someone who is currently or was previously in a dating or intimate relationship with another person. It can include a wide range of behaviors listed here. There are many commonly referenced barriers to conducting IPV screening, but all are unacceptable reasons. There's time for critical healthcare interventions, and screening is the first step to get people to the care and resources they need. RADAR outlines the steps to identify and respond to IPV patients you may encounter. Remember, ask, document, assess, and review. The first 4 screening tools here, HARC, HITS, PBS, and WAST, are expanded upon in the Women's Health module. But the number one takeaway from these screening tools are common themes in what questions to ask, how to ask them, and using a screening tool as a neutral opportunity to accomplish that on paper. If you have a patient with a positive screen, it's important to first immediately develop a safety plan and be familiar with your facility's protocol and referral or resource coordinations with social and mental health services, as well as community programs. Speaking of resources, here are a few that you should know about. Additionally, when it comes time to interview a patient who may have experienced IPV, the SOS-DOC framework is very helpful. It uses normalized language by avoiding the feeling of being singled out, and the provider sends a message that it's not just you. You offer and discuss various services that provide tailored safety needs like women's shelters, support groups, legal advocacy, and document what you've observed and discussed, and form continuity with follow-up and assessing barriers to their access to resources. The physical exam is the most anxiety-producing part of the encounter, and there are techniques you can use to both promote patient safety and build trust. Firstly, always asking permission and explaining the exam and procedure before and during allows for consent and autonomy to stop at any time. Start with the most non-threatening parts of the exam before moving to more sensitive areas, and allow them to shift parts of clothing instead of becoming completely undressed. Some minor verbiage choices can make a big impact. Be sure to call it the exam table, a table, not a bed. And as always, pay attention to nonverbal cues, things like becoming anxious or nervous, uncomfortable, and offer the patient the time and space for a break. We've pulled out the 2 most sensitive exams, the breast and pelvic exam, and highlight general rules to follow. ACOG has released the 4 C's to trauma-informed care: claim, contain, care, and cope, with common themes that we've discussed that involves the attention to patients' affect and feelings to provide empathetic patient-centered care that gives the patient the autonomy in decision-making. As always, knowing available referral options is critical. Here's a few. If you'd like to learn more, please check out our Women's Health module. The pediatric population is an important one in the trauma-informed care discussion. ACEs, a type of trauma, and the relationship between those and health outcomes has been investigated and broken down into the 3 subjects we've discussed previously. It's shown a strong dose-response correlation between ACEs, their risk behaviors, and disease condition, meaning they're cumulative. So if you've experienced more adverse events, the higher your ACE score, and the more likely you're going to have poorer health outcomes. Screening allows you, as the provider, to refer the patient for the care they may need, support adaptive coping, provide basic information, and anticipatory guidance to parents. The American Academy of Pediatrics does not approve or endorse any specific tool for screening, but here's a quick guide of ideas on things to ask at different times. Always touching base at every visit for updates outside of the annual or establishing care visit where the whole gamut of questions is asked. There are age-specific tools for trauma. The Pearl screen is for children aged 0 to 19 and includes a screening for ACEs and a screen for additional adversities and is available in 17 different languages. The SEEK questionnaire is for parents and caregivers and can be used as a screen for prevalent psychosocial problems such as parental depression and substance use. Here's a quick example of signs and symptoms you could look up for in your pediatric population that could be concerning for trauma. It's important to note a lot of these are pretty vague, so it's mostly to keep it on your differential in every patient that you're seeing. Here are some resources for the pediatric population for screening tools, and a full list of other referral and resource options to be on your radar. And as always, remember that you can help mitigate the health consequences of trauma and ACEs by breaking the cycle of adversity with trauma-informed care. Thank you all for your time.